Good afternoon, everybody. The topic for my presentation is fundus albipunctatus as an incidental finding. So fundus albipunctatus is a rare congenital stationary disorder which is associated with night blindness, and it belongs to the group of syndromes known as the flecked retina syndrome. The inheritance is autosomal recessive, and the gene most commonly mutated is RDH5. There are characteristic small pale yellow or whitish spots in the perimacular and peripheral retina at the level of RPE. Despite so many lesions, there is no significant vascular and optic disc abnormalities. So coming on to the genetic background, the RDH5 gene is located on chromosome 12, 13 and 14, and it has 318 amino acids. It encodes for 11-cis-retinol dehydrogenase, which converts 11-cis-retinol to 11-cis-retinaldehyde, which is the universal and chief chromophore of visual pigments. This is abundantly found in retinal pigment epithelium, and missense mutation is the most common mutation. However, you can also see frame shift and in-frame mutations. Coming on to the case report, we had a 70-year-old female who presented to the medicine emergency with the complaints of headache, numbness of left side of body and vomiting. A diagnosis of CVA with left cerebellar infarct was made after seeing the ECG changes. Hence, the patient was sent to the ophthalmological OPD for the routine fundus examination to rule out hypertensive retinopathy. There was no significant history pertaining to night blindness, delayed dark adaptation, poor color vision, impaired peripheral vision, or any other similar complaints in the family members. Ocular examination, the visual acuity was 612 in both the eyes, color vision was within normal limit. Anterior segment examination showed NS1 ISC in both eyes. Post-mediatic fundus examination showed multiple round yellow-white spots distributed throughout the peripheral retina, sparing the central retina. The FR was dull and there was mild attenuation of the vessels. The investigations corroborated with the findings of fundus albipunctatus, as the OCT showed discrete, highly reflective lesions at the level of RPE. The ERG showed depressed rod response. The HFA24-2 showed significant visual field constriction. The FFA was not done as the patient had a recent history of stroke and the KFT was deranged. This is the fundus photograph of the patient. And this is the HFA24-2 image showing significant visual field constriction, which is more in the right eye. Now coming on to the differential diagnosis, the three differential diagnoses are fundus albipunctatus, retinitis punctata albicans, and Stargardt's disease. The fundus findings are similar in all the three cases. However, the visual fields are normal in fundus albipunctatus, constricted in RPA, and might be constricted in fundus flavimaculatus. Retinal vessels are normal in fundus albipunctatus. They are attenuated in RPA, and they can be attenuated in Stargardt's disease. ERG shows depressed rod response, and after prolonged dark adaptation, it shows a proper scotopic response. In fundus albipunctatus, in RPA, it is depressed in both the cases, and it is variable in both the cases in case of Stargardt's disease. So the most probable diagnosis for our patient is fundus albipunctatus. However, a probability of it being RPA cannot be ruled out since the lesions were mid-peripheral, and the genetic testing can be confirmatory in this case. No active intervention was required. However, the patient has been kept on long-term follow-up for progressive corn dystrophy. Such patients may not give a history of defective dark adaptation also. Thank you.
Thank you.